Hello, welcome everyone to the Rural Emergency Hospital Education. We have a packed agenda today. We're going to start with giving you a brief overview. If you joined us before, you may have seen some of this information that we have, but if you're not familiar, we'll be going over the REH designation, and at a high level, we'll review the policies and requirements of being an REH. We're then going to talk a little bit about the Rural Health Redesign Center and the technical assistance that's available to all of you. And then we are excited to have George Pink, Senior Research Fellow at the Sheps Center for Health Services Research, join us today to highlight some recent findings from a research study on REHs, and then he'll also share some lessons learned. Afterwards, we'll close out our session today with some Q&A and then also identify resources and next steps. As always, we want to note that the work of the Rural Emergency Hospital Technical Assistance Center is funded by HRSA. And with that said, the contents of this presentation do not necessarily represent the official views of HRSA, HHS, or the US government. And so today we have Ken Harman, the Program Director of the Rural Emergency Hospital Technical Assistance Center here at RHRC. And I'm Rachel Tarpley. I'm a project manager here at RHRC supporting the REH Technical Assistance Technical Assistance Center, and I will be your moderator today. And then before we get started, just want to review some housekeeping items. So you'll notice that you are on mute, and this is just to minimize any background noise. We also have the Q&A feature, so feel free to ask questions, and it's available either at the top or bottom of your screen, depending on your layout. If you need any closed captioning, that is available. You can click on the 3 dots and where it says More. You can then select language and speech and then choose your preferred language. And lastly, the slides and recording for this webinar will be available on our website within 1 week of this event. And then if you have any follow-up questions, you can email us at rehsupport@REHRSA.gov. And then I just want to go over some of our objectives today. We want to provide you a high-level overview of the REH, review REH policies and requirements. We also hope that you learn a little bit more about us and the technical assistance that we offer to the rural emergency hospitals. And again, the most of this presentation will be spent learning about hospitals that have converted to an REH. So with that, I'll turn it over to Ken, who's going to give us a brief overview of the REH and just talk about some of the technical assistance that's available to you.
Thank you very much, Rachel. I appreciate the opportunity to be here and with Dr. Pink to be able to share some of the findings and information about the Rural Emergency Hospital Program. At the RHRC, we are honored to have been selected by HRSA and CMS to be the Technical Assistance Center for the Rural Emergency Hospital. I'll just give us a very brief overview of who we are and what we do. We're an organization that is designed to really protect and promote access to high quality healthcare in rural Pennsylvania. That was our roots, and now across the entire nation. We do this through partnerships and improving the health of the communities in which we work and serve. And as an organization, we now have visited with and interacted with over 413 hospitals and communities across the United States as we've had conversations about rural emergency hospital, and have assisted a number of organizations in determining that designation was the appropriate designation for them, and we've been able to help them progress and move. Like she said, today I hope to give just a very brief overview of the REH program, the eligibility and the criteria around the REH program, and then a little bit more of a discussion about, as a technical assistance center, how we work with our partners in the state offices of rural health and the hospital associations and other partners to facilitate getting this information out to various communities and hospitals so they can determine if this is something that can help their communities. Now, the program, the Rural Emergency Hospital, was built back on December 27th of 2020. That's the date the federal government passed and created this new designation for hospitals. I guess the impetus for the creation of this program was they saw a dramatic increase in the number of rural hospitals that were closing, and they saw that many rural hospitals around the country were struggling to maintain positive operating and total margins. And so this government said, let's see if we can come up with something that will enable the continuation of some of the core essential services, predominantly the emergency room and lab and imaging and clinic services and other services in these areas. I always like to go back to a good friend of mine, Connie Martin, who was in Colorado, and she said, where people live should not determine if people live. And the whole impetus behind this rural emergency hospital program was to create a structure and a type to enable many communities that would have their hospitals closed because they couldn't sustain themselves under the PPS model or under a critical access model. And so these are those opportunities to help that. Now, this isn't for every hospital in the country. As we've indicated, I said we've helped 413 hospitals, and we've had a lot of conversations with them, and many of them we've told them, no, the model that you're currently under, the critical access designation or the PPS model, those may be a better fit for what your goals and objectives for your community are. But many of these hospitals we've looked at and said, no, this is the proper designation. And so there's a few requirements you have to be able to participate. Number one, you have to be in a rural area. If you're in an urban area, this is not a model that will that you can apply for. You also have to either be a critical access hospital or a small PPS hospital that was fewer than 50 beds, and you had to be open and certified as a Medicare hospital as of December 27th of 2020. We've had a few hospitals that closed in 2016 or 2017 that reached out and said, hey, we'd like to reopen. And I said, well, talk to your senators, get the legislation changed. If you were open on December 27th, we can help you. If you closed prior to that, I'm sorry. But this is a great program that has helped a lot of hospitals. Now, there's certain services that are absolutely required and essential that you must provide as a rural emergency hospital. Number one, you have to have an emergency room open 24 hours a day, 7 days a week. You also have to have observation services available all of the time. Now, that doesn't mean you're going to have patients all the time in observation. That doesn't mean you're necessarily going to have patients in your ER all the time. In fact, I'm up here in Montana today in a hotel room, and I spent a lot of time with one of our newest rural emergency hospitals this week. That happens to be in Jordan, Montana. Very small hospital. Average daily census for them in their ER is 1 or 2 patients, and that meets the criteria. They provide observation services. They have an emergency room. We have other hospitals that see hundreds of patients a day. So there's really a spectrum on that. In addition to that observation care and that emergency room care, you're also required to provide lab and diagnostic services. You're required to have a pharmacy process to ensure that the medications are available for your providers as they provide that care. And you have to have a discharge planning process. You don't necessarily have to have a person who's designated solely as your discharge planner, but you have to have a process that's in place to facilitate that. And obviously, the competencies and documentation of those competencies for those people doing that. In addition, there's a lot of other things that the REHs can offer. This is not an exhaustive list. I just put together a few items that could fit into this. Basically, you can do almost anything on an outpatient basis, whether that's routine labs or telehealth, or going through and having your clinics, or some of your substance abuse, outpatient intensive programs. In addition, if you like, you can have a distinct part skilled nursing facility. Obviously, that's separately licensed under Medicare, but these are a few of the services that we have. We have hospitals that are doing lots of surgeries. We have a couple hospitals that are doing total joint replacement surgeries. There's a very significant spectrum of what you can do. And obviously, as we visit with these hospitals and help them, you look at the individual hospital, what are the needs in those communities, and what makes sense. Probably at the core of the Rural Emergency Hospital Program is the financing of it. The program looks at and wants to make sure that they can provide a framework so these hospitals in these communities can become financially viable and be I guess, a program to take care of the needs of their community for years and years to come. A large portion of that has to do with a monthly facility payment. Happens to be about $3.6 million this year. After sequestration, that works out to be about $295,000 a month. That payment comes in every single month. And that payment has helped many of these hospitals to be able to pay for that fixed overhead, those costs associated with providing that emergency room and that lab and that imaging and the clinic and these other key services. In addition to receiving that monthly facility payment, they also continue to receive payments for the services that they provide. Now, the services that they're providing, these outpatient services we talked about, they get paid either on an outpatient perspective payment system or on a fee schedule patient, depending on the type of patient. For those services that are OPPS-based payments, they get OPPS rates plus 5%. For obviously those things that continue to be on the fee schedule, they get the fee schedule. Now, those are the real positive things on the financial side. With every designation, there are strengths and weaknesses. Some of the things that go away that the REHs have to close is they have to close all inpatient services. The Rural Emergency Hospital is an outpatient-based hospital. So you close those inpatient services and obviously lose any of those financial fees associated with those care. Currently, you're also required to close your swing bed services. Now, you can keep those patients if you have that distinct part nursing unit and you can shift it to that SNF. But since in a hospital setting, swing bed is an inpatient service, that also gets closed. Currently, they're not eligible for 340B program pricing. And if you happen to be a critical access hospital, you're no longer allowed to be able to have that cost-based reimbursement. And so, in addition to this eligibility and the scope of services you have to have and the services you can't have, the federal government, when they put this program together, required certain documents that you have to go through. This action plan, which, to be honest, is really a great transition plan. When you turn this in and you decide you want to become a rural emergency hospital, you have to include those services that you're continuing, those services you're discontinuing, how you're facilitating those discontinuation of services, where are they going to go, showing that you have a transfer agreement and you have arrangements to be able to send some of those people that used to be in your inpatient beds, where are you going to be sending them? You go through and talk about how you're going to staff the organization. You're talking about how you're using that monthly facility payment to facilitate the provision of care within your community. And then you have some attestation documents as well. The Rural Emergency Hospital Technical Assistance Center, we provide a lot of assistance pre-conversion for these folks who are evaluating and determining whether this is something they want to do. We will meet with them. We sign a non-disclosure agreement with those individuals and those organizations. And we come through and help them put together a financial model. We help them look at strategic considerations. We help them look at communication processes. If this is something they're interested in and it makes sense, how do they communicate to their employees? How do they communicate to their community? How do they communicate to their medical staff? And all of this process and putting together these action plans and other documents is part of all of this pre-conversion assistance that we provide. In addition to the pre-conversion assistance, we also have a lot of post-conversion assistance as well. And we will certainly help organizations after they've converted to continue to improve their processes to, number one, make sure they can achieve this financial stability. Number two, to make sure that they become regulatorily compliant with the new conditions of participation and the processes, to help them evaluate and determine what are the things they can do to better meet the community's needs? What are services they might be able to grow in that outpatient sector to better take care of their community and help their organization become more financially strong and viable? And what do we do to assist them in transition planning and ongoing support as healthcare changes and the dynamics change? And so lots of technical assistance, both on the pre-conversion and the post-conversion, a lot of partnership and work with our state offices of rural health and hospital associations and other partners as we help navigate and help these organizations move forward. Now, the process of conversion is not terribly difficult, but it does take a little bit of time. As the organization goes through and does this assessment process, that can take weeks. And we have had a few organizations that have taken years as they have continued to say, it's not right for us right now. And then we continue to work with them. We had one hospital that we worked with back in 2023 that just recently applied. They needed to wait for their organization. They had to try a few other things first, but eventually they said, yes, this does meet our needs and apply. And so that assessment process normally takes a little bit, a month to 2 months, but we have had some organizations that say take years, and that's okay. The application process is pretty simple. It is a change of application. So it's not a new application through PACOS, it's just a change application. And we go through and fill out that application, submit some supporting documents. The MAC's then going to review it. The state's going to get involved in reviewing processes. And then obviously CMS will be involved in reviewing those processes. And so all of this work and all of this stuff we're doing, again, I just wanted to provide this brief summary. The Rural Emergency Hospital Program is an absolutely great model for many hospitals. We have found, currently we have 51 approved and operating rural emergency hospitals around the country. The vast majority of these organizations, had they not converted to rural emergency hospitals, would have ended up closing. And so the thing that I'm passionate about that gets me excited every single day to be able to help hospitals and interact is the fact that this program that the federal government came up with is helping hospitals to keep their doors open, helping them to keep taking care of people. It's not for all hospitals, like I said. Those that we've really helped tend to be smaller, low volume hospitals, but absolutely it's making a difference. I'm now going to turn the time over to Dr. George Pink and allow him to tell a little bit about the process that he and his organization has gone through. So, Dr. Pink.
Thank you, Ken. I appreciate it. Greatly appreciate the opportunity today to present. I'm going to start off by uttering two phrases that you never hear in the same sentence. I'm a university professor, and I'll be brief. One of the great joys of being a university professor is I get to work with very smart students, and this study I'm going to present is the work primarily of Aditya Palutla, who is now graduated and is on the job market and soon to be paying taxes for the first time in his life. And I'm very happy to be able to present it on his behalf. The same disclaimer for us as Ken just gave you a few minutes ago for the RHRD. Ken is going over this, so I'm going to skip this slide and really focus on the second slide. So I'm going to present you two sort of studies. There are two parts to his honors paper, from Aditya's honors paper, but I'm going to, and they're very different parts. The first is going to compare converters to non-converters, and the second is going to compare the profitability before and after conversion to REH. The second one, what's relevant in this slide is that essentially, because you're giving up inpatient services, the hospital then avoids or reduces its costs because it's not having to provide 24-hour-a-day inpatient care. In exchange, it gets, and it loses the PPSOCH reimbursement, cost-based reimbursement for those services. But then when it converts, it then gets the outpatient or enhanced reimbursement and the monthly payment of around $295,000 a month that Ken mentioned. And that's what we're going to be evaluating. What is the net effect? That's what profitability essentially is, revenue minus cost. What are the net effect of conversion? As Ken mentioned, there are 51 rural emergency hospitals around the country right now. They're primarily in the south, as you can see. There's some in the Midwest as well, and a few up in the Pacific Northwest. But they are really, the majority are in the South and Midwest. In terms of who they are, previously 23 of them were critical access hospitals, almost half. That sounds like a lot, but in proportion to, if you put the total number of critical access hospitals over the total number of rural hospitals, that's a much higher percentage. So the critical access hospitals are actually statistically less likely to be REHs, even though they form the largest group here. Sole community hospitals are the next largest group, and you can see the rest of them there. There's only 5 Medicare dependent hospitals. The RUCAs are a measure of rurality, if you like. And over half of them are in very isolated rural areas. Again, consistent with what Ken was saying about being in small rural areas with low volumes. And finally, by year of conversion, January 1st, 2023 was the first day that hospitals were eligible to be REHs. You can see there are 18 in the first year, 17, and then 10. We've had 6 so far this year, so there's 51. Only 1 is actually closed since the program began. So there are 2 very specific research questions I'm going to present. What are the organizational financial characteristics of hospitals that actually choose to convert to REH? And the second one is, how did profitability change? So essentially, who's converting and how are they doing in the vernacular? This is mandatory for any academic. You have to have a method slide. You go to a PhD school, they tell you thou shalt include a method slide. But the important point here is that in the first research question, we're converting converters and non-converters. Well, who are the non-converters? In this study, the non-converters are all those hospitals, the CHs and the rural hospitals less than 50 beds, less than or equal to 50 beds, that could convert if they wanted to, but have not converted to date. So we're comparing an apples to apples. There's no good comparing an REH to a 100-bed rural hospital, because a 100-bed rural hospital is not eligible to be an REH. So this conversion is 2 groups of hospitals, those that have converted, those that are eligible to convert but hadn't converted. The second research question, we're really looking at the converters only, and it's a pre-post study. What was their profitability before conversion, and what has happened to profitability after conversion? This is all the data we controlled for many different characteristics. We have explored a lot of data. I don't think there's anything here I want to concentrate on specifically. And then for the second one, again, we looked at operating margin, total margin in particular, but we looked at other things as well. I'm just going to selectively present a selected amount of data because there's no way you want to listen to me present all the data for all those variables. So the results. You can see in this slide that these are the characteristics that we found were most distinguishing between non-converters and REH converters. The first thing you can see that jumps out at you is that they are much, much smaller from a net patient revenues perspective. 9.2 million versus $30.8 million. The number of FTEs, again, much smaller than the non-converters. And again, number of acute beds, the average being 21.5 versus 25. And that just reflects a lot of them are rural critical access hospitals. But then again, on a variety of other indicators as well, you can see that the percentage of hospitals that convert that are critical access is 39.6% and so on. So you can see, although critical access hospitals are a large number of hospitals, the number that have chosen to convert so far is a relatively small percentage. And it's a small percentage because there's just so many CHs around. Some of the other the financial measures, if you like, that we found were really important. And the one that stands out more than anything else is the profitability. And you can see in the first 4 rows, depending, choose your margin. It really doesn't matter. That compared to non-converters, which all have positive margins, the median for the converters were all negative. This is, again, before conversion, remember. So you can see that they are very, very different groups of hospitals based on profitability. You can also see less days cash on hand, a smaller debt service coverage ratio, and a negative debt coverage ratio in the terms of REH converters. So I think any financial analyst would look at these kinds of numbers and say, REH converters, before they converted, were in much worse financial condition than the non-converters. In terms of this is exploring organizational characteristics. You can see on the right that it's essentially the same map I showed you a minute ago, showing where the rural emergency hospitals are. On the left is a map from our website of where all the rural hospital closures have been, 195 of them since 2005. And you can see there's certainly a similarity in pattern in terms of being focused primarily in the South and Midwest, a few in the Northeast. I'm kind of curious as to why California has not, the model has not yet attracted much interest in California, given that they've had quite a few closures themselves as well. This data Ken very graciously provided to me. It shows that how the state approval processes that are required for an REH to convert. Some states use legislation, some used administrative rules, and there's actually 14 states so far that have not passed legislation. Ken, I'm going to put you on a spot here. I heard that South Carolina passed legislation last Friday or Thursday. So these numbers, that 14 may now be 13. Is that right?
Absolutely. I mean, this is an ever-changing document as organizations go through and look at that. So South Carolina in the legislature actually passed it on April 24th, but it took a little while for them to then get signed by the governor and for the state Department of Health to go through and kind of put their rules and regs together. So yeah, this slide's already a little bit dated, and certainly will be changing. You know, there's a few other states like Arizona that is looking at rulemaking and probably doesn't have to have legislation. And so there are different areas that are in process, but this is reasonably accurate based on the information we have to date.
Okay, well, I strive for reasonably accurate. It's one of my life goals. Some of the character non-converters did not differ on some financial ratios. That's frankly surprised me somewhat. I'm surprised they were relatively similar in equity financing, Medicare, inpatient payer mix. I was very surprised that there was not much difference in Medicaid payer mix or that there was any difference in ownership between independent and system affiliated. I would have thought there'd be more independence. I would have thought the converters would have a much higher percentage of Medicaid. But yeah, you know, we're just reporting the news. This is the kinds of statistical analysis that our undergraduates learn these days. I will try and explain it. Essentially, these are 4 box plots of before and after conversion. On the right is total margin. On the left, on the left is total margin. On the right is operating margin. And I'm going to just pass this. I'm going to defer this for 1 minute because I think there's another slide that might be quite easier for people to understand. I think this really tells the major story, though. What we did is we compared the 4 or 5 cost reports before conversion to REH, and then we compared the 1, 2, or 3 cost reports after conversion to REH. This is based on 32 hospitals, not 51 hospitals that I told you about a few minutes ago, because not all hospitals that have converted have got post-conversion cost reports yet. But 32 is still a pretty healthy number. And you can see that in the cost report before conversion, so the very last cost report that the hospital submitted as a CH or as a PPS hospital, the median operating margin was negative 22% and negative 17.9% total margin. And then in the cost report, the immediate cost report, the one right after conversion, the first cost report after conversion, the median was plus 5.4% for operating and plus 7.4 for total. Those are fairly substantial gains. In fact, I don't think I can remember very often seeing such a dramatic change in profitability from one cost report to another cost report. And the story is even more dramatic, I think, in this scheme, in this figure. You can see here the 4 cost reports before conversion to REH are in yellow on the left. You can see the line going through the box, the line in the middle of the box, that's the median. The top of the box is the 75th percentile, and the bottom of the box is the 25th percentile. So the yellow boxes are half of all the rural emergency hospitals. And you can see that half of them, and probably more because most of them are below 0, you can see a downward descent in profitability. As they get further and further along in time, they're losing more and more money. And then there's the line, and that's the date of conversion, like when the day they changed from PPS or CH to REH. And then the green boxes are their total margin, or this is their total margins after conversion. So you can, again, this is the jump of 25% percentage points that's described in the previous table I showed you. So I would say that is a fairly dramatic change. This is the operating margin, not quite as dramatic because it's just operating results, but still fairly impressive change in profitability. So what have we found then? What did Aditya find? They're much smaller. Our rural emergency hospitals that have converted compared to those that have not converted are much smaller, more likely to be an MDH or SDH from a statistical point of view, much less profitable, less liquid, less able to service debt, and more likely to be in the South. I think the only conclusion I can draw from this second analysis is that the early results of profitability seem to be promising. They seem to show that they are resulting in an increase in operating margin and total margin. The implications of this study, we think, there's probably quite a few, but some of them are prominent ones, I think, are first, state offices, rural health should be targeting small rural hospitals that are financially distressed, low patient numbers, low patient revenue, as potential conversions to REH. Those are the hospitals that are likely to be most interested and likely to benefit most from conversion to REH. Because the map shows such variation in the adoption of REHs across states or between states, our hypothesis is that there are not only different levels of distress, but different states have got different amounts of policies that support rural hospitals. Georgia and North Carolina, for example, have got rural hospital stabilization funds. Other states have got very little support for rural hospitals. So state policies and the enabling legislation may also be a factor that explains the differential adoption rates by state. And then finally, the profitability results suggest that the REH program so far seems to be on path to achieving what was intended by the legislation, which is to provide an alternative model for rural hospitals to consider that's a little more financially viable over the long run than PPS or CEH reimbursement. Every academic has got to have limitations, and limitations to our study is we use the cost reports before and after conversion. Some of them had less than 365 days. Some of them were missing some data, but again, the title of the brief that this is drawn from is an early look. So it is an early look. And then we've only had 1 or 2 cost reports since conversion. And so again, it is an early look and a limited look. I'd really like to thank my colleagues who helped with the study, particularly Aditya and Christy Thompson in particular. There's our resource, there's our websites. If you want to get any of the data that I've shown you today, all the maps and so on are all on our website. And that's all there is, folks. Thank you, Ken.
Thank you very much, Dr. Pink. We certainly appreciate this. And again, we preface this by saying this is 32 hospitals. And we'll certainly be able to have a future review as more of these hospitals turn in additional cost reports, and we can look at it and see what's 2 years out and 3 years out and 4 years out. But again, to me, the study stands for itself. But more importantly, I look at the individual hospitals. You know, I was visiting with one of the hospital CEOs, and his comment to me was prior to conversion to the rural emergency hospital, he and his organization were having conversations with their board about do we close down? This program has made a difference to patients in his community. There are people who rely on these emergency rooms. There are people who rely on these clinics. There are people who rely on these hospitals. And for these hospitals and for this program, it's made a lot of difference in the lives of individuals around. Now, Dr. Pink and I are certainly happy to answer some questions. We did have a couple questions I know come in when people registered, and maybe I can address a couple of those, but then we'll open it up for those that do have questions. You've got a question and answer component on the slide presentation. Please feel free to put any of those questions that you have into that document. and we'll facilitate that. So one of the questions that came in is, in this initial assessment process, does this Technical Assistance Center assist organizations about including the feasibility of this program, and does it look at the provision of additional services or redesign of an organization? You know, they may have had a 25-bed inpatient unit, or like one hospital was had almost 50 beds of an inpatient unit, and when they shut it down, you have all of this space. So is this assessment looking at what can you put in those spaces? The answer is absolutely. Initially we are looking at a financial model that says these are the services you lose revenue-wise, these are the things you get. But then we work with the organizations. We put together an out-migration report, or our partners that we work with, Mathematica helps us put together an out-migration report. We put together a service line analysis, which really looks at their community. What can they be doing differently? And over time, some of this in some organizations happens very quickly. Other organizations, that financial stability and kind of regulatory compliance takes a little longer for us to work with them. But absolutely, the answer is the technical assistance process for the organizations that have used it does include both the feasibility and additional services and the redesign of the space that they have and the services they could provide. A second question that came up and says, okay, so rural emergency hospitals are no longer getting cost-based reimbursement. Do they still have to turn in cost reports? The answer is yes. Cost reports is one of the tools that the federal government collects data to help them understand what's happening in hospitals. So it's not just critical access hospitals that turn in cost reports. PPS hospitals do, large academic medical centers do. We have the rural emergency hospitals do that as well. So yes, it may be a different and a simpler cost report, but you still have to do it. Third question that came in, it says, since this is a new program, sometimes some insurance companies aren't aware of it, and their initial take is, hey, that we don't cover that. I had an example. We had a hospital in Kentucky reach out to us that's a rural emergency hospital and said, hey, TRICARE says that they don't participate in the program. The answer is yes, they do, but obviously the folks at TRICARE in Kentucky were not aware of that. And so we've worked very closely with CMS. We worked very closely with HRSA and others, and we communicate these questions that come up and get answers for them. For that particular hospital, we're setting up a conversation with another REH that is part of the larger system, and they're willing to provide some resources to that particular REH so they can go through and make sure that they get that information. And so answer is sometimes we hear new questions and new things comes up with insurance companies, but almost all insurance companies are covering it. There are some changes because obviously it's a little different. You're not providing inpatient services. Medicaid, as an example, has some states that have made state plan amendments and do things, and a few other states are in the process of doing state plan amendments. And so there are different dynamics, but the answer is yes. All insurance companies will provide the services. Sometimes we have to help them understand what an REH is because they don't understand initially. And the last question that we had a number of places asked is said, hey, I know that we have hospitals that are interested, but they can't convert unless we see things change. So swing bed and 340B and other changes. Is there legislation coming forth? That's always difficult for us to say, and our job as a technical assistant is not to advocate and to try to change, but we're to educate. And the answer is there are some senators who are working very diligently behind the scenes and are hoping to introduce some legislation this month to facilitate some of the changes in the federal law. If their proposed changes come to fruition, swing bed would be one that would be reconsidered. Having a national fix so the states don't have to do state plan amendments for Medicaid would be there. And so there are a number of fixes, but I always come back and say, I don't know how fast Congress is going to change. And just because we have a number of senators who are proposing it, once it gets approved and signed, we'll share that information. I hope it changes, because I can tell you, out of the 413 organizations over the last 3 years that we've worked with, we have a lot of them that said, hey, we would look at it if it included swing bed, or we would look at it if it just included 340B. And so if the government makes those changes, we'll certainly go back to those organizations and say they've now made those additions and changes, and we're happy to redo a model for you and help evaluate whether that's appropriate or not. I've been in healthcare long enough to remember when the critical access designation was passed, and it's the same thing that happened there. They had to make iterations and changes to fix unintended consequences and to make changes to that program to make it more effective. REH is no different. Changes will occur, and some are being proposed, but again, I don't have that crystal ball to know if it will happen or not. So those were the questions that came in from the registration process, where we asked if you had questions. So I'm now going to open it up. Are there any other questions that you have for me, or for that matter, for Dr. Pink, as he talks about the study and what his student found?
So we have one question in the Q&A asking, is the action plan, transfer agreement, and attestation to REH COP submitted to the state or CMS via along with the 855A?
Thank you. And the truth of the matter is in most cases, it's both. The federal government, when they're putting their packet together and having the MAC do that initial review, they do require the action plan and a transfer agreement and an attestation. So those are the federal requirements. But most states also require that. And there are a few states that require some additional pieces of information be shared as well. So absolutely, yes, when you're submitting your 855A, which is that change application, you do have to submit these 3 documents. And that transfer agreement is just not a generic transfer agreement. There has to be a transfer agreement with a level 1 or level 2 trauma center. You as an organization can certainly have more transfer agreements than that, but the legislation wants to make sure that you at least have one transfer agreement with a level 1 or level 2 trauma center. And so, yes, those all have to get submitted into the federal government, but in almost every case, the state has similar requirements when you put in an application with the state for this change of status as well. Number of states have required maps showing exactly what portions the hospital is going to be, what portions inpatient, and now what's going to be outpatient. Some states require different documents. New York, as an example, requires some additional documents around how you go through a certificate of needing closing services and things. So each state's a little different, but at the Rural Health Redesign Center with the technical assistance, we can help work with the states to go through that process. And in a lot of cases, we work very closely with the state offices of rural health or with the hospital associations to facilitate. I'll give an example. In Kansas, whenever we have hospitals that are doing this, we work very closely with the Hospital Association and Jennifer Findlay, and the Hospital Association is very much involved in offering to assist with community forums or town halls to to communicate with the community. I've worked very closely in Nebraska with the State Office of Rural Health, and we're kind of putting together a toolkit for hospitals that are looking so they can understand all of the state requirements, and we can get those processes done even more easily. I could go through and talk about probably 30 or 40 different states that we work with on that, but those are just a couple examples of how we have to do that. So, Mr. Stubblefield, I hope that answered your question there. And we did have someone ask, will you share the slides? Absolutely. Rachel will facilitate those getting posted on our website in about a week?
Yes, it should be on our site in about a week.
Perfect. Any other questions? I might add, I know a number of you are representing state offices of rural health and other things. We just recently worked with a number of different hospitals, and we've created some different videos that tell the story from those hospitals' perspectives. And so we'll try to get some of these out to the state offices of rural health so you can see some of the videos and some of the information. I've looked at the study that Dr. George's student performed, and I'm going to be going through and looking some of the cost reports, and I might be reaching out to you at the State Office of Rural Health and say, hey, I'm noticing you got 6 hospitals that appear to be, less than $10 million or $12 million in revenue, and it looks like they've had 2 or 3 years of negative things. How can we collectively work together to approach that hospital and see if they're interested? So we'll work with you. We need your help on that, but let us know. We also had Jennifer Findley state that the Kansas Hospital Association is happy to talk. So if there's anyone in another state that wants to talk about legislative fixes, reach out to Jennifer. Jennifer has been absolutely involved, not just in the state of Kansas in helping get things fixed, but she and the Kansas Hospital Association has been working very, very closely with their federal senator to facilitate some of this national legislation. So Jennifer's offer here is that if any of you want to reach out and talk about some of the legislative fixes, she's willing to share that. Dr. Pink, there's a question for you. It says, what other research questions do you think you're looking at, or have you heard of others looking at moving forward?
Yes, thank you for the question. Boy, academics love getting questions. So what other research are you going to do? We're going to be in the next few months, another student will be looking at the sources of profitability gains from REHs. So essentially looking at the highest possible level and sort of accounting 101, revenue minus expenses equals income. Is the increase in profitability, is it growth in revenue? Is it reduction in cost? Or is it both? And so we're going to be looking at that as a short-term study we're going to be doing. I was at the Rural Health Issues Group in meeting in DC earlier this week. They're going to be doing 3 studies in the coming year. One is looking at the same sort of things we're looking at, the sources of profitability. The second is going to be looking at beneficiary access, what happens to local residents' access in the community after REH goes forward in terms of access to outpatient care, inpatient care, and so on. And the third study is going to be what is the effect when a hospital converts to REH, what is the effect on other local hospitals in terms of their inpatient volume? Does it, that the REH loses the inpatient volume? How does that affect the other local hospitals? Do they pick it all up, or what kind of patterns exist? So those are the only 3 studies I've heard of being done by MedPAC, plus the one we're doing ourselves. Thank you for the question.
Thank you. And I might mention at the Rural Health Redesign Center, we're putting together some learning briefs or best practice things that we're seeing at rural emergency hospitals. And so we're looking and saying, how are some of these rural emergency hospitals through really preparing and becoming more regulatory compliant with a continual survey readiness processes? What are the things that hospitals that are effective in that, what are they doing? We're looking at some of the things around infection control and antimicrobial stewardship. What are some of these really successful hospitals implementing to help them have better and more robust programs? And that question that was asked earlier, kind of around service line and expansion growth, what are some of the hospitals doing once they get some of that financial stability and some of that regulatory compliance? What are they doing to look at their community needs, and how are they expanding services to go through, and kind of outlining kind of a step-by-step process that other organizations could use to be able to do some of that. So yeah, we've got some of those things that we're certainly doing and working with. I think we have a couple other questions. One of them says, do you have a sense of community satisfaction? The answer is yes, but that's all anecdotal right now. We have a number of hospitals that do good employee or satisfaction studies. We have some hospitals that do patient engagement surveys. We have a few that have done some community outreach, but the vast majority of them have not yet. And so we what I'm going to tell you is really anecdotal based on what the hospitals are telling us. The vast majority of these hospitals, the communities are very grateful that the hospitals are still there. They are perceiving it really well. Initially, after conversion, a number of the hospitals have had some community concern because of the closure of inpatients. To be honest, more of them have had some concerns about the closure of swing bed services. And there's been a couple hospitals that had heard, oh, I thought that you had closed. And so they've had to re-engage their community with open forums and community meetings to do that. But the vast majority of hospitals are very positive about the fact that they're now financially stable, and that for the first time their employees are feeling like they have a stable organization. I had a hospital in New York that told us they were using travel nurses all of the time. They had staff turnover that was really impacting their organization. Since converting to rural emergency hospital, they've now gone 18 months with no turnover in their nursing area. They're not using agency staff because they were able to reallocate their nurses and take care of them. The staff satisfaction is dramatically happier because now they're in an organization that they believe is going to keep their doors open, and they're not worried about, am I going to lose my job? So lots of positive sense of community, but long term, I'd love to be able to do that study, but we need to get a little more data points before we can do that. I had talked to Dr. Pink and said, hey, can we do something like that? And he's like, absolutely, we can do a study like that, but we got to figure out how in the world we measure it. And so we're not there yet, but does that. Jennifer Finley also put in the comments that said, lessons learned from Kansas. You cannot over-communicate with community members. It's an absolutely critical part of the conversation. And I can tell you that the the Kansas Hospital Association did a lot of work in those communities in facilitating this communication. And one of the hospitals in Kansas, their community, and a number of them at the senior center still thought the hospital was closing. And so the hospital association and the hospital had to re-engage and have a second meeting and a third meeting. But I would tell you that's the case on any hospital, whether you're converting to an REH or not. Your communication and openness with your community is very, very important. Again, we want to thank you for participating. I think that's all of the questions that we've had come in so far. If you have other questions that come up after the fact, feel free to shoot an email to us. But I'll turn the time back over to Rachel. I don't know if you needed to cover anything else. But if not, on behalf of Dr. Pink and myself, thank you for spending the time and listening to us. And again, let us know how we can help. We're honored to be your partners and honored to be able to help some of these hospitals keep their doors open and keep taking care of members of their community. So thank you.
Thanks, Ken. So just to reiterate, if you have any questions, you can email our team at rehsupport@rehrco.org. And our presentation will be posted onto our website in about a week. Thank you again for joining and have a great rest of your day.